So cancer essentially is a genetic condition. It may or may not be inherited. Right? But cancer essentially is a genetic condition. So geneticists have all right to discuss about cancers. So what is a germline mutation? See, these are basic concepts. Just I told you about C dot number. When you give a nomenclature, where you provide minus sign, where you provide plus sign during a mutation nomenclature in the new single gene disorders. So what is a germline mutation? No, mosaicism can be there in the father's or the mother's germ cells. So during formation of germ cells, right, if there is a mutation and it affects few of the germ cells, right, so that is germline mosaicism. So whenever a baby is born, if that baby has that mutation, so it is first time the baby is born with that mutation, right? A germline mutation is a heritable mutation. A germline mutation is a heritable mutation, inherited mutation. Germline means inherited. What is the opposite of germline? Somatic, correct. So germline is an inherited mutation. That baby has inherited it from one of the parents. And when he or she has his or her offsprings, so through her or his germ cells, right, it will be passed on to the offsprings. If it is dominant 50% of the offsprings, like that, right? If both copies have the mutations, then all of them will carry at least one of the mutations. So a germline mutation means an inherited mutation. A somatic mutation is after formation of the organism, there is a mutation in a cell, right? So cancer can be somatic mutations, right? Or one of the mutations can be a germline mutation, the other hit is a somatic mutation, right? So be very clear with this concept. What is a germline mutation? What is a somatic mutation? So somatic is after the organism is formed, there is a mutation in one of the cells which incurs a property to the cell that there is proliferation, extensive proliferation, then there is cancer, right? So is familial cancer and hereditary cancer same? So we use the term interchangeably, but they are not really same, right? A familial cancer is a cancer which is seen in the family. Most of them would be inherited or heritable cancer, but many of them can be just clustering of certain cancers in a family due to their lifestyle, right? Due to their lifestyle. So so whenever we tell a germline mutation of a cancer, we tell about hereditary cancer syndromes or hereditary cancers, right? We all know about these things. There is something called proto-oncogenes and there is something called tumor suppressor genes. Proto-oncogenes promotes cell growth and proliferation, and tumor suppressor gene inhibits excessive proliferation, right? So they keep on working simultaneously, and when there is a mutation which activates the oncogene, there is malignant transformation or excessive cell growth, or there is loss of function of a tumor suppressor gene due to a mutation, then the inhibitory part of cell growth is not there, then there will be malignant transformation, and what we get is a cancer, right? So remember that in a cancer, either an oncogene is activated or a tumor suppressor gene is suppressed, right? And we have a list of genes. So I deliberately had made these colors. We have a list of genes that NF1 is a tumor suppressor gene. BRCA1, BRCA2 for breast cancer are tumor suppressor genes. P10, you know about these genes, so I have encircled this because these are known genes. P10 is a tumor suppressor gene. VHL, von Hippel-Lindau disease, you know, cerebellar hemangioblastoma, pheochromocytoma, that is a tumor suppressor genes. So for all, for retinoblastoma, you know, RB1, retinoblastoma, it's a tumor suppressor gene. So for tumor suppressor genes, you need both copies of the genes to be mutated. Okay. Common genes like RET proto-oncogene, MEN2A, multiple endocrine 2A. Then KRAS, HRAS, they have cardiofasciocutaneous or Costello's, some mutations. So PIK3, CA, these are few genes which you know they are proto-oncogenes. So even one copy gets mutated, there will be activation and they will get cancer, right? So you know Knudsen's two-hit hypothesis. This is the first or the foremost example of how retinoblastoma genes require two hits. So you know that if one gene is affected, they don't get retinoblastoma. A second hit is there in the same cell and there's loss of both copies of the gene and they get retinoblastoma. You know retinoblastoma is eye tumor. So it's a tumor suppressor gene. So there is a one hit, whether this is somatic or a hit is inherited. There is a second hit after the organism is formed, which is definitely a somatic hit, and they get cancer, right? But for a proto-oncogene, even if there was no hits, and they might get cancer with time, right? A single hit, they will get cancer. For tumor suppressor genes, it requires two genes. So all said and done, in a cellular level, when a proto-oncogene is involved, it is dominant. And at a cellular level, when a tumor suppressor gene is involved, it is recessive, right? In a cellular level, it is recessive. But when you see the inheritance, you will see that for retinoblastoma, it can be sporadic. That means there is two retinoblastoma genes. There is one somatic hit, then there is another somatic hit, and they get tumors. So this type of tumors, which is sporadic retinoblastoma, which is 60% of all retinoblastoma. You know, retinoblastoma is a childhood eye tumor, right? So there is inactivation of a tumor suppressor genes and it requires two somatic hits. So you see that there is no family history of such, and there will be one child affected with that. So most of the time, sporadic, there will be single tumors or unilateral, one eye is affected, or sometimes later onset, and there is significantly risk to the family members. But you have to get mutation done in the child, and you can screen extensively in the family if there is an inherited mutation, right? Because 40% are familial retinoblastomas. So there is one somatic hit in one allele, then another somatic hit, and they get cancer. So that is very much understandable. But for a familial retinoblastoma, there is one inherited mutation, right? Then there is another somatic hit, and they get cancer. But for them, suppose one of the parents might have a risk of cancer. One of the parents might have retinoblastoma. So most of them will have multiple or cancers in the both eyes, and they can have other cancers as well, right? So it is recessive at cellular level, but when you see the family, it is dominant, right? Because one of the hit is inherited, one of the mutation is inherited. So there is one inherited mutation in 40% of all retinoblastoma, it is familial, and the second hit occurs in the family. But remember that for a dominant condition, so this is inherited, the penetrance, so will all people have a second hit? No, so all people won't have, even if he or she inherits gene, mutated gene, they might not have cancer, but for them, it is almost around 90%, right? So 90% will have, so when there is a hit, almost 90% will have a retinoblastoma, will have a second hit. So 90% is the penetrance. See, 1% have a retinoblastoma, it is familial. His father also had or mother also had retinoblastoma. We know that it is inherited. Now he will pass on this mutation to 50% of his offsprings. Among this 50% offsprings, 90% will have a retinoblastoma, 10% don't have. So it is not 100% penetrant. So it is around 90% penetrant. So 90% will have the second hit, 10% won't have the second hit. So hereditary cancer at apparently autosomal dominant transmission of specific cancer. They have earlier age of onset. There is multiple primary cancer in an individual. You know that when there are a lot of cancers, they can be secondaries, but there is multiple primary cancers in an individual, because you know that these tumor suppressor genes will be there in every cell of the body, right? Then there is clustering of rare cancers in a family, and the cancers will be bilateral or multifocal for all heredity. First degree relatives of the mutation carriers are at 50% risk of having the same mutation. And incomplete penetrance and variable expressibility, I have taught you during my teaching, and also in the next day you have heard about inheritance, autosomal dominant inheritance. So there can be incomplete penetrance or variable expressibility. So obligate carriers may be cancer-free, and age of diagnosis of cancer might vary because we do not know when the second hit will appear. Those who do not carry mutation has population risk of cancer. So 50% will carry the mutation, 50% won't carry the mutation. So those who will carry, it will depend upon the propensity of the cancer to manifest due to a second hit, which is called the penetrance, and can be variable expressively, so age of onset might vary. But for familial cancers, there are more cases of specific types of cancer within a family than statistically expected, but no specific pattern of inheritance, right? Like dominant, ऐसा नहीं भी हो सकता. Then age of onset may be variable, may result from chance clustering of sporadic cases, because you know colon cancer is very common, breast cancer is very common, and may result from common genetic background, environmental, lifestyle factors, does not usually exhibit classical features of hereditary cancer syndromes. Sporadic cancers as cancers in the family are likely due to non-hereditary causes. Even if there is more than one case in a family, there is no specific pattern. Typical age of onset is variable. Very low likelihood that genetic susceptibility testing will reveal a mutation. So hallmarks of families with hereditary cancer syndrome are 2 or more relatives in a family being diagnosed with cancer. So remember this, whenever you do counseling for breast cancer, whom to test, whom not to test, you have to remember this. If there are more than 2 or more relatives, her mother or her grandmother also had breast cancer, her cancer is diagnosed in less than 50 years of age, same type of cancer in several family members, more than one type of cancer in one person. If there is more than like von Hippel-Lindau disease, there will be either pheochromocytoma and also associated cerebellar, endolymphatic sac tumor, pancreatic. So more than one type of cancer in one person. A rare cancer has occurred in one or more members of a family. So these are hallmarks of hereditary cancer syndrome. And the typical examples are adenomatous polyposis colon. You know, there are thousands and hundreds and thousands of cancers, polyps in the colon, right? And some of them might be hematomatous, some of them might get transformed into malignancy. Then non-polyposis colon cancer, also called HNPCC, basal cell Neves syndrome, breast and ovarian cancer, and these are men 1 and 2. Then VHL, von Hippel-Lindau disease, Cowden syndrome. You know, Cowden syndrome is due to PTEN mutation. So these are classical autosomal dominant hereditary cancer syndromes. But there are autosomal recessive cancer syndromes as well, right? For them, you require 2 hits and both hits are inherited. For them, you require 2 hits and both hits are inherited. So while you do a pedigree, you find ataxia telangiectasia. You know, they have telangiectasias like this. And before adolescence or near about adolescence, they become wheelchair bound, or they will be lying in bed. They lack all forms of activities. They have immunodeficiencies. And ataxia telangiectasia, they will have ataxia. Bloom syndrome, Fanconi anemia, Rothman syndrome, Werner, most of them are DNA repair defects. Because of the defects in DNA repair, they will have multiple types of cancers, right? So there are some or very classical example of autosomal recessive cancer syndrome. So I will see that cancer is occurring in the siblings and both the parents will be carriers. The examples are these, right? Then there are some cancers where there is uncertain inheritance and we do not know, but there is clustering in the family. And there are some genes also known for them. So genetic counseling and risk calculation. So what is the benefit of genetic counseling? You quantify cancer risks. In the individuals who are having a chance of carrying a mutation, facilitate syndrome identification, like you have von Hippel-Lindau syndrome, you have multiple neoplasia type 2A, where you know that there will be medullary thyroid cancer. So you can tell that your family has main 2A. So there is a very common mutation for main 2A. We can check it, and we can check all your family members who have that mutation. There can be prophylactic thyroidectomy for main 2A. Prophylactic thyroidectomy is for family FAP, that is adenomatous polyposis colon. Prophylactic colectomy is done, total colectomy, right? You get a mutation in one of the offsprings, and you start doing colonoscopy very early. You start surveillance very early. You find cancer, you do total colectomy. Then developing plan of management, screening, prevention, risk reduction. So all these are benefits of genetic counseling. Then understanding the psychological and emotional responses that occur for those who increase risk and those who do not carry the mutation. It is reassuring that they won't be having cancer. They don't require surveillance. Previously, for familial polyposis colon, all the offsprings were getting annual colonoscopy. Now what we do the mutation. Those who have the mutation, we start doing annual colonoscopy, and after certain age, they go for total colectomy. And those who do not get the mutation, we do not do annual colonoscopy. For von Hippel-Lindau disease, you do annual MRIs. You keep on doing annual MRIs to detect. For NF2, neurofibromatosis type 2, keep on doing annual MRIs. They are all inherited in autosomal dominant fashion. Now we do not do, right? Those who carry the mutation, we screen, we put them on surveillance. Those who do not carry the mutation, we tell there is no need. So that is a very important thing of doing a molecular test. And we also know what is the disease, how big is the gene, what test we should do. Then what is the risk of genetic counseling? There is definitely psychological aspects like anxiety, depression, and somatic complaints. Before then social communication barriers between test positive and test negative individuals in the same family. Then there is disbelief and re-evaluation. Then they keep on looking for symptoms. They are preoccupied with cancer. Oh, this is a inherited cancer. Then my child might also get a cancer. When the child becomes slightly bigger, he or she is preoccupied. Then there can be inaccurate risk assessment, failing to account for gene and gene environment interaction, and unrecognized variation in penetrance and expressibility. As I have told that not all cancers, all people who carry the mutation will have the cancer. So for each cancer, you have to know what is the penetrance during counseling. So steps are client's personal and family medical history, risk calculation, and conveying risk. Then pre-test counseling. Before doing a molecular test, we do a pre-test counseling and take informed consent, then ordering the test, then interpreting the test result, because you know there will be many VUS. So VUS will, not all sequence variation is actually causing the cancer, might not be pathogenic, but whenever there is a breast cancer there, even if that sequence variation is not causing or causing, we do not know, they will report that, and you are at a trouble what to do with that. Then interpreting test results and post-test counseling is required. So personal history has age, major illness in the past, reproductive history, and in cancer, which organ is involved, what are the number of cancer, what is the first stage of diagnosis, because you know that pheochromocytoma, they are adolescent cancer tumors. Many of them might not be inherited. Pathology, stage, grade, and treatment regime. Family history, you have to get 3 to 4 generation pedigree, a detailed medical information about probans, first, second, and ideally third degree relatives. Standardized pedigree symbols and nomenclature should be used, because that goes with the family, the whole family tree, who are having the cancer, what is the difficulties, whether other things like intellectual disability is also there in the family. Then ancestry, ethnicity, and consanguinity needs to be documented. You should also document whether there is a carcinogen exposure for relatives who are deceased, those who are not living. Note the cause of death and age in the same family. Then it's a dynamic process because after sometimes most of the cancers might be adult onset. So after sometimes the person's estimated cancer risk might change with additional relatives diagnosed with cancer. So it's a dynamic process. So they require multiple visits to your place. Then how risk calculation is done? There is something called absolute risk, defined as probability that an event will occur, that is developing this over a defined period of time. Like they carry a retinoblastoma gene, inherited cancer, you will tell that 90% of the people will have, and most of them will be childhood onset. Then there are age-specific risk, like a woman might have cumulative risk of 30% lifetime risk of breast cancer, but her risk for next 5 years is 5% only. So this is age-specific risk. So they will be coming next 5 years, what is the chance? Because after that, she might have some other important task to do in next 5 years. Then there are interval risk, that is lifetime risk divided into defined age intervals. Then there is relative risk, like what is the risk of developing a cancer as compared to the population risk, right? So that is called relative risk. So those who do not have the mutation, they will have population risk of cancer. So odds ratio is a good way to mention the relative risk. Basics of risk calculation is hereditary syndrome showing Mendelian inheritance. You know the mode of inheritance. It is autosomal dominant, except for those which I have told are autosomal recessive, like ataxia telangiectasia, Bloom syndrome. Then you have to know the penetrance of the cancer. FAP is 100% penetrant. Familial adenomatous polyposis colon is 100% penetrant, right? So for each disease, you have to know the penetrance. Then you can tell. Then underlying genes have been identified and a gene test may be available and recommendable. Clinical presentation and family history may be pathognomic, diagnostic, or at least highly suggestive of a syndrome, right? So these are the basics of risk calculation in a Mendelian. For non-Mendelian, then you measure clustering of cancer in family members. It is very difficult to have risk calculation for non-Mendelian disorders, but there are certain risk models as well, like Gale model and Claus model for breast cancer, whether it is hereditary or non-hereditary, right? So they will ask how many relatives have, what is the age of that relative, then whether it was bilateral, what is the histopathology of cancer. So all these things will be taken in account and they will have a risk calculation. What is the risk? So, but for a person, the risk is either 0% or 100%, right? So for them, 30%, 60%, 80% sometimes becomes very difficult, right? So there are empiric risk models also, like through the inheritance pattern you can find out. The limitations of studies are largely based on Caucasian women and difficult to assess risk if there is a lack of family history. Sometimes they will not have big family history, but there might be cancer. Then there is a very small family side. Deaths at young age in at-risk individuals, lack of verifiable cancer diagnosis in the family. So they will tell probably had some gut abnormalities, but they do not know whether there is a colon cancer or not. So these are the limitations of risk assessment models. Then you convey risk in percentage or fraction, ranges, discuss the chance of never developing the cancer. So if you have a molecular test done, you will discuss the chance of never developing the cancer in the same. Then verbal and non-verbal cues are used to assess the patient's understanding and acceptance. Molecular genetic test for cancers. You have to remember that most of the time, even if cancer is there, genetic tests are not covered in insurance. Medical insurance won't cover genetic tests, so that might be really difficult. So, and there can be insurance discriminations once one cancer is thought to be found to be heritable cancer, right? So insurance will give medical insurance to every person with diabetes, every person with cancer. But once you have a molecular diagnosis and you have made that it is a genetic cancer, it's an inherited cancer, there can be insurance discrimination. You have to be very, very cautious, and during counseling, you have to tell them that you really want a test done and whether you have a mediclaim. And even if the test is done, it is good not to disclose it to your mediclaim people. Have it with you have your cancer assessment risk, but for those people who have the cancer, get admitted, get operated, get treated with chemotherapy. But so you have to remember this, right? Then there is psychological impact in mandating a pre and post-test counseling. So in most cases, it is not simple and clear-cut results may be there. So you have to tell that we are testing you for colon cancer, but there might not be a clear-cut gene. And we don't find a gene we don't find a mutation does not tell that you don't have a heritable cancer. There can be deletions, duplications. What we do is do our cancer balance or NGS test. So there can be deletion duplications. There can be mutation in other genes, which you do not know. Then there is exceptional extreme mutational heterogeneity and variable penetrance. And it is difficult to interpret that whether if you have a variation, your child have the variation, whether that child will develop a disease or not, according to their penetrance. Like main 2A, it is very, very penetrant, right? So we'll do prophylactic. You had classes on genetic testing in children? No. So you know that if they cannot give consent, you cannot do genetic testing. If for pre-symptomatic children, if the child has symptoms of SMA, DMD, will do. But the child do not have symptoms of DMD, you cannot do early genetic testing. Right? It is untreatable. DMD as of untreatable. Main 2A may manifest in the adolescence, in the adult. Right? But for genetic testing, where there is a treatment, familial adenomatous polyposis colon, there is a treatment, there is a provision of surveillance. So you test in children. So these cancer syndromes, where there is provisions for surveillance and treatment, you can see, you can test in the children, right? So this is an important. Otherwise, for those disorders where there is no treatment, for Huntington disease, you don't do pre-symptomatic testing. Even in adults, you have to tell them. But a person who is above 18 years for Huntington disease, they might want to know that if I have Huntington disease, I won't go in a sports where it requires fine refinement. I won't play table tennis. I won't play table tennis as a career option. I won't do surgery as a career option. I will do medicine, right? So they might want to know whether they have Huntington disease. Huntington disease, 50% of them will have the disease. But for children, you cannot do. Before 18 years, when they cannot give consent, you cannot do a test where genetic test, even if there is chance that he or she might have a disease, carry a disease, you cannot do a test if they are not in a age to give consent. But for these familial cancers where there is treatment, you will do a test in a child, right? So child age is 12 years. For other consent, you take an informed consent for parents for any research, right? But a consent of an adult is 18 years. If suppose a person has a family has Huntington disease, a family has spinocerebellar ataxia, which is autosomal dominant, only after 18 years you can test them. You take consent and you test them after 18 years. It is not ethical to do testing in an unaffected child with consent of parents when there is no treatment available. Main 2A VHL, where there is surveillance, familial adenomatous polyposis colon, so heritable cancers, there are surveillance plans, specific surveillance plans. So there you test children. Because you have surveillance plans, you can detect cancer early, you can treat early. So when it changes your treatment plan, management plan, you can do testing in children with consent of the parents. Otherwise, if the parents want that I want a child to be tested for such a disorder like DMD, BMD, or SCA, which might manifest, or Friedreich's ataxia, right? So you cannot test. You cannot test if they are not 18 years. So the pre-test counseling informed consent is required. Then there are psychological aspects like anticipated reaction to results, timing and readiness of testing, family issues might be there, confidentiality issues are there. Sometimes they don't want to tell to their spouse, to a person whom they want to get married. So you have then utilization of tests for medical surveillance and preventive measures, storage and potential reuse of genetic material. So all these psychological aspects are there. Informed consent should include purpose of the test and who to test, General information about the disease and the gene. Risk associated with gene mutation include the concept of penetrance and variable expressibility and possibility of genetic heterogeneity. Then possible test results. What will be the possible test results and what will be your action after that? Result reporting and post-set counseling. It is provided in writing that this is variation which was found, which is being interpreted as likely pathogenic. So if it is likely pathogenic, 90% of those who are likely pathogenic or 10% or almost all of them who have this variation will develop this cancer by this age. And it should be done by the referring clinician only. And with report, you can always have raw data, clinical interpretation of test results, sensitivity, specificity, and references. Molecular testing issues for certain cancers. So you know that for all women, 1 in 9 women can have breast cancer. So breast cancer is a very, very important form of cancer. But up to 10% have BRCA1, BRCA2 mutation. So 10 to 15% will be inherited cancers, syndromes or breast cancer. For rest, 90%, 80%, 90%, it is non-inherited. So you have to tell them that whenever they come, but you have to remember those rules. If she is manifesting below 50 years, if there are multiple family members affected, you have to go for cancer testing, panel testing, all this, and BRCA1, BRCA2 testing. So mutation and variants extremely heterogeneous, and they are very large genes. So what you require are generally NGS for breast cancer. Sequencing of whole gene is not required if the mutation in the family is already known. One of them has the mutation, the second person has the disease, or they want to screen adult woman. You only do targeted sequencing with Sanger, right? You don't do. If there is a familial mutation known, or there is a ethnic mutation, right? Like Ascension Jews have 3 recurring mutations. So there is a small community which is marrying between themselves. So there will be, then you don't do whole gene sequencing, you can only do Sanger. No, NGS, no. See, for BRCA genes, 80% are sequence variations. Around 80% are sequence variations. So you do NGS. NGS and Sanger is for sequence variations, substitutions, 1-2 nucleotide deletions. So they are not included in MLPA. MLPA is whole exonic deletions. Though the probe binds and can detect a single mutation, but rest 20%, which may be due to deletion, duplication, other things, will tell about BRCA. So if there is a classical family presenting below 50 years, you do an NGS, you suspect BRCA1, BRCA2, you don't get it NGS, then you ask them that there can be large deletions which will not be picked up by NGS, because NGS will amplify one allele, no, the other allele is not amplified if there is a large deletion. So you do MLPA then. No, BRCA is a large gene and there are 2 genes with very similar manifestations. So you do NGS. For breast cancer, you suspect hereditary breast cancer, you do NGS. You have a very strong suspicion, then you do MLPA. Am I clear?
No. Please explain.
For all genes, you know that mutations are more than 90% mutations in the exons, right? Each disease has its specific mutation ways, right? Like for DMD, it is exonic deletions or small amount of duplication. Duchenne muscular dystrophy. So what you do is MLPA first. 70% are due to deletion duplication. So you do MLPA first. For all other disease like breast cancer, familial breast cancer, more than 80% or 80% are due to sequence variations. Sequence variations means C to T change, एक T गायब हो गया sequence में, है ना, exon में ऐसा है. So you cannot do it by MLPA, no. MLPA probe will bind somewhere else. वो C to T, there are more than 200, 300, 400 nucleotides in an exon. MLPA is for exonic deletions duplications. Rest 20% जो होगा ना, large deletion, large exonic deletion होगा तो वो दिखेगा नहीं, NGS और Sanger में नहीं दिखेगा. The other allele is normal, so it will amplify. वो ऐसा sequence दिखेगा, CTTT दिखेगा, normal दिखेगा. Am I clear? If there is a large deletion, large exonic deletion, the other allele will amplify. और उसका सीक्वेंस आप मैच करोगे रेफरेंस सीक्वेंस से, वो नॉर्मल दिखेगा. बट इन MLPA you will see heterozygous deletion because it is doses analysis. एक में बाइंड करेगा, दूसरे में बाइंड नहीं करेगा. एंड हम उसमें क्या करते हैं, उसी का सारे प्रोब्स के साथ एंड अदर्स इसके साथ कंपेयर करते हैं MLPA में. So there you see heterozygous deletion in exon 1, exon 2, exon 5, anything, है ना. Then you tell that your family has a deletional form of mutation, है ना. In the next family member or for screening you do MLPA then. Then in microarray also you won't find, right? Microarray exonic deletion नहीं दिखता है microarray में. So sequencing of whole gene is not required in very specific conditions, otherwise you sequence. So BRCA1 or BRCA2 is the second most common test offered for pre-symptomatic testing after Huntington disease. So remember that BRCA and BRCA2, you know about the story of Angela Jolie-Jones, no? So now with NGS being price has come down so much, so it is very common. And likely pathogenic or pathogenic mutation, you tell that your lifetime risk is 50 to 85%. Don't think that you will definitely have breast cancer. So what you need is surveillance. What you don't need is the mastectomy, है ना? So prophylactic mastectomy नहीं करना है. Prophylactic mastectomy नहीं करना है because the penetrance is 50 to 85%. But you know that ovarian cancer is very dreaded, है ना. उसको surveillance करना बहुत मुश्किल है. And she has crossed the age where she does not require ovary. Then they can do prophylactic oophorectomy, right? Because the penetrance of having ovarian cancer is again 25 to 50%. So you know that ovarian cancer is very dreaded. उसका कोई उतना अच्छा surveillance plan है ही नहीं ovarian cancer का. So उसके लिए they can do prophylactic oophorectomy after if they have mutations, right? So prevention and treatment is available or not. So these are things about breast cancer you have to tell in post-breast counseling. Again, for colon cancer, most of them are sporadic. Only very small percentage are familial or hereditary. And the classical example is adenomatous polyposis colon, where there are more than 100 polyps in the colon, I have told you. And there are others like Peutz-Jeghers syndrome, where again there are hematomatous polyps in the colon, and it sometimes becomes difficult to diagnose them or separate them. But you know, Peutz-Jeghers has a very specific skin and tongue manifestations, Peutz-Jeghers and those. So these are conditions where there can be hereditary colon cancer. Some of them are due to PTEN mutations as well. So you have to remember this. Most of them are sporadic. And if there is a syndrome diagnosis, then probably it is good to do, or there are multiple family members. Again, same rule applies, less than 50 years, multiple cancers in the same family, you go for mutation testing or genetic testing. Von Hippel-Lindau disease, again, there are multiple cancers, like cancers in the brain. There is cerebellar hemangioblastoma, very classical of von Hippel-Lindau. There can be retinal angiomas, there can be endolymphatic sac tumor in the ear, there can be pancreatic cysts and small cancerous pancreatic cancers. Then there is pheochromocytoma in the adrenal glands. Classically, they might start presenting in adolescent with pheochromocytomas. This is a small gene. Like for breast cancer, adenomatous polyposis, and colon cancers actually have a lot of different types of genes having similar manifestations. So there your answer is NGS. For VHL, it is very classical. Your answer is Sanger sequencing. There are only 3 exons and we do Sanger sequencing. I have told you that we will PCR amplify and sequence the exons from forward, then again from reverse. So VHL is classical Sanger. So this is a cohort of our patients. So what does this mean? So C dot number I told ATG from A, it is 1, which is the coding sequence number, right? C to T, C is replaced by T. And what does this mean? P dot? Huh? Protein, correct. So in protein, see the P dot number will be around 1/3 of the C dot number because you know it is triplet codon. So here arginine has changed into a stop codon, right? So again, this is a missense mutation. This is a nonsense mutation. So this is a nonsense mutation where a codon has been replaced by a stop codon. This is a missense mutation, right? So this is our cohort of patients where we have cerebellar hemangioma is fairly common. Pheochromocytoma is very common. First tumor is pheochromocytoma in a very large, but there can be small pancreatic cysts also, which will start with, they might start with. So these are our cohort of patients. And this is our cohort of, this is the gene, it's a small gene. These are the various tumors like hemangioblastoma, renal cell carcinoma, they can manifest with renal cell carcinoma as well. So these are the various mutations and pheochromocytoma, sometimes other tumors. So we have made this diagram and we have published this in last year. So this is an example that if you have lab facilities, you can really screen these patients. So this is our work we have published. So thank you so much. The take-home messages are, remember that if it is a young age of onset, multiple affected family members in a family, multiple cancers in one person, then you suspect hereditary cancer syndrome. And many hereditary cancer syndromes have very specific manifestations, molecular testing as per suspected diagnosis. So don't do NGS for everybody, right? If you suspect MEN2A, there is one mutation which is present in more than 50%, around 50% of MEN2A. Do a single Sanger sequencing for MEN2A, and all cancers are inherited as autosomal dominant fashion, except those few which are due to repair. When repair is defective, there you require both alleles, inherited alleles to be defective, right? Otherwise, all cancers are autosomal dominant, whether it is due to proto-oncogene, whether it is due to a tumor suppressor gene.